Hello, everyone, and thank you for joining us. My name is Ambrosia Greer, and I am here presenting alongside Rachel Holm. Our presentation today is titled Assistive Technology Mounting and Wheelchair Positioning for ALS. This continuing education module aligns with the ACOTE standards and it emphasizes evidence-based interventions, clinical reasoning, and interdisciplinary education. Our objectives are to identify occupational performance challenges in ALS and connect them to the OTPF4 domains and processes. So to apply these evidence-based interventions for wheelchair positioning and assistive technology mounting systems. To demonstrate measurable outcomes using the validated tools such as the ALS Functional Rating Scale, and the Canadian Occupational Performance Measure, and the Functional Mobility Assessment, the FMA. So by the end of this presentation, you will be able to apply research-supported strategies to promote independence, comfort, and participation for clients living with ALS. Next slide. All right, so the overview that we have here is that ALS is a progressive motor neuron disease characterized by degeneration of both upper and lower motor neurons, resulting in weakness, spasticity, and eventually loss of voluntary movement. The average age of onset is between 55 and 75 years of age, with an expected lifespan of 2 to 5 years post-diagnosis. So ALS presents complex occupational performance challenges, impacting self-care, communication, mobility, and social participation. So as us occupational therapist practitioners, our role is to extend beyond these and support them with adaptive participation through interventions and environmental modifications. Evidence highlights that the importance of timely assistive technology introduction, allowing clients to maintain autonomy and reduce the psychosocial stresses associated with the loss of the function. So early power mobility and AAC planning have been shown to prolong independence and improve the quality of life when implemented proactively within our care. Okay. All right, so here's the OTPF4 and how we can integrate it. Okay, so the positions of the OT processes dynamic and clinical, beginning with evaluation, guiding intervention, and measurable outcomes. During the evaluation, practitioners analyze client factors such as tone, endurance, posture, and sensory processing while considering environmental demands and contextual supports. Interventions include customizing wheelchair seating, mounting communication devices, and training both clients and caregivers in safe functional use. Outcomes are measured using standardized tools like the COPM, the ALSFRS-R, and FMA, which capture performance change and satisfaction. The OTPF4 emphasizes that occupational engagement is the ultimate therapeutic outcome, making technology not merely compensatory, but instrumental in restoring roles in participation. Okay. Here we have the assessment toolkit. So our assessment framework integrates both disease-specific and occupational-based tools to ensure holistic evidence-driven evaluation. The ALSFRS-R measures disease progression across 4 domains: the bulbar, fine motor, gross motor, and respiratory. In one of our studies that we found, the Baker and colleagues validated its factorial structure and sensitivity to change. So the COPM assesses individualized performance and satisfaction scores with a 2-point change indicating clinically meaningful improvement. The functional mobility assessment, the FMA, developed by Kumar, states that evaluates mobility across the MRADALs and demonstrates strong test reliability, making it suitable for wheelchair and assistive technology outcomes. Some of the measures, like the wheelchair skills test and the wheelchair outcome measure, quantify functional satisfaction and participation levels as well. So combining these assessments allows us to connect physiological changes with real-world occupational outcomes, aligning with AOTA's emphasis on functional client-centered data. Okay. Here, we have some seating interventions is fundamental to ALS management. As weakness and fatigue progress, optimal positioning becomes essential for pressure management, respiration, and functional engagement. So according to the RESNA positions paper, effective measures redistribute requires at least 20 degrees of posterior tilt combined with 10 to 30 degrees of recline, maintained for 2 to 3 minutes at regular intervals. Research supports that this combination significantly reduces ischial pressure and enhances blood flow compared to static sitting. Micro tilts throughout the day improve compliance, while proper foot and pelvic support stabilizes pressure and conserves energy for activities of daily living. So the OT's role is to prescribe and train tilt recline dosing schedules, educate caregivers, and document clinical justification linking seating to occupational performance. Okay. Mounting systems are often underappreciated, yet they are critical to both safety and independence. The ISO standard defines structural testing for postural support and mounting hardware, specifying static and impact load requirements for wheelchair components. Clinically, mounting systems must preserve neutral posture, allow quick release removal, and maintain visual access without obstruction the field of view. Improper positioning can result in cervical strain, eye fatigue, or compromised safety. And OTs apply ergonomic and biomechanical reasoning to determine optimal device height and angle, ensuring clients can communicate or access technology comfortably and safely. Adherence to ISO standards protects both the client and the practitioner by supporting evidence-based, defensible recommendations. So pictured here is a Monty 3D Plus HD, is a wheelchair mount with a long reach and high level stability, made of tubes measuring 500 by 500 by 400, and it comes with a U, DS, and DC as an additional tube to maximize the device load capacity. Okay.
Okay, so moving on to communication, adaptive technology, and access methods. So, communication defines participation, early integration of AUC devices or augmentative and alternative communication. Systems are now recognized as a quality indicator for care. So, in one of the studies, we found that Andreasen, I don't know if I'm saying that right. Sorry, guys. It demonstrated that individuals using eye gaze technology experience significant psychosocial benefits, included their autonomy, their self-esteem, and their connection with others. Um, so the eye gaze and switch-based system should be introduced proactively before speech intelligibility declines. So when ocular motor control deteriorates, hybrid systems, like combining steady state visually evoked potentials with eye tracking, can extend communication access. For the OT's clinical reasoning part, it ensures that mounting and calibration and environmental lighting are optimized to reduce fatigue and maximize the individual's accuracy. Ooh, have to go fast. Um, so our task is not merely to provide a device, but to preserve the client's voice agency and social participation through every stage of the disease progression. So pictured here is a system for disabled people with restricted mobility or limited mobility. It's called the Independence Drive. So this allows people to move their wheelchair by looking at one of the 8 points on that tablet right there. And that actually tracks their eye movements through a camera. Moving on to the next. So, interdisciplinary collaboration. Um, So, effective management of ALS relies on a multidisciplinary approach, of course, as we all know. So, as the OT, we would lead in translating motor and postural analysis into functional relevant adaptive technology interventions. So, the SLPs would be responsible for guiding the AAC symbol systems, the voice banking and message preservation, and they would also collaborate with OTs for the ergonomic placement and access on the chair. For physical therapists, they would help us contribute to posture, balance, and transfer safety, while also assistive technology professionals will ensure that basically the technology is compliant and the funding supports the technology. And then as far as like neurologists, respiratory therapists, and social workers, they'll help us integrate medical, respiratory, and psychological dimensions. Research from these interdisciplinary ALS clinics demonstrate that collaborative care models extend survival and improve quality of life compared to fragmented approaches. Um, we are essential as OTs, we're essential to these teams as facilitators of communication, documentation, and educating. We kind of full circle it. So, for patient and caregiver education, education obviously represents both intervention and prevention. So, as OTs, we need to teach safe and sustainable routines for seating, mounting, and energy conservation. We have evidence-based guidelines, of course, that recommend performing tilt to 20 degrees, recline to 10 to 30 every 30 minutes to prevent pressure injuries. So, OTs can train caregivers to check the mount clamps, verify quick release functions, and schedule AAC use during high energy periods to prevent fatigue. For the OTPF4's health management occupation, it includes routines that maintain physical well-being and a caregiver confidence. Providing written checklists and visual prompts reinforces learning and carryover. So when clients and caregivers understand the rationale behind each step, they're more likely to be compliant with it, and it's gonna improve one's safety. So, a little case example we have here. This is Debbie, a 74-year-old woman with bulbar onset ALS. She reported difficulty communicating with her family and discomfort during prolonged sitting at church. So, the OT team conducted a COPM assessment identifying two prioritized goals, one of texting independently and attending church for 2 hours without pain. The intervention included prescription of a power wheelchair with tilt recline elevating leg rest, a contoured cushion, and an eye gaze speech generating device mounted to midline. Um, so after 8 weeks, the OT reported a +3 improvement in both performance and satisfaction on the COPM and improved FMA scores. Her ALSFRSR domains remain stable, demonstrating how evidence-based OT interventions can maintain the participation even with the decline of her disease. And then for key takeaways, so basically to summarize this all, occupational therapy, as we know, leads ALS care by uniting evidence, empathy, and interprofessional collaboration. Early adaptive technology and seating intervention upholds dignity to the individuals and preserves their independence as long as we possibly can. Research also supports tilt recline positioning, structured outcome tracking, and psychosocial benefits of AAC devices. OT's measures progress using reliable tools like the COPM, FMA, and ALS FRSR, that's a mouthful, to justify continued services and demonstrate medical necessity. Ultimately, the OT's role is to ensure that every device and every posture leads back to participation, that we are helping further their independence and saving every little bit of function that they have and building off of that. And that's just the heart of our profession to do that. And then these are our references. Thank you guys.
Thank you.